Greetings to you all once again. And it's time for Africa. It's time to breathe life into Africa. My name is Dorothy Honeybender, the founder and president of the Africa Respiratory Care Association. And you are all welcome once again to this webinar. This webinar is brought to us by the Africa Respiratory Care Association, and our mission is to reduce the burden of respiratory diseases by strengthening the workforce in Africa, providing innovative solutions, and then enhancing respiratory care. You can visit our website on www.africaresp.org for more details and information about the Africa Respiratory Care. This webinar is proudly sponsored by a great company called Zopec Medical. And Zopec Medical is a medical device company that produces the world's smallest and lightest UPS battery designed for critical care, mobility, transport, and emergency backup away from bedside. And this helps clinicians provide heat and humidity whilst transporting or mobilizing the patient. For more of Zopec Medical products, kindly visit them on www.zopec.com, or you can reach out to them via sales@zopec.com, or you can also contact the Africa Respiratory Care Association and ask about these product or about our sponsors, and we can give you full details of what you need. I also want to appreciate all our participants and anyone that has supported in one way or the other. So including yourself, you are highly appreciated. And today we are going all the way to Sierra Leone. And our presenter is a Sierra Leonean. She has worked in clinical research and healthcare in the UK for over 14 years, sorry. She has a strong background in science, clinical research, drug study, and specializes in smoke cessation and respiratory health. She is the co-founder of the Breathe Well Initiative, a charity organization dedicated to strengthening asthma and COPD care between the UK, Sierra Leone, and across Africa. Her name is Madame Adama Fofana. Madame Adama Fofana is so passionate and about the equity in respiratory health care. She works to empower patients, train professionals, and inspire global collaboration in respiratory health. Madam Adama Fofana, your audience, our presenter. Thank you.
Thank you very much, Mrs. Bender, for that introduction. Firstly, as you said earlier on, I'd like to thank God Almighty as well for the grace He has given us and the amplitude to carry this assignment. And I want to, thank you, Mrs. Bender, and all the ARCA team for giving us the opportunity to share our work with everyone here today, and also those that will listen later on. And I thank the predecessors for all the wonderful presentations that they have done. I have learned greatly joining those webinars. It's been very educational. Secondly, I'd like to thank the following people for their considerable support and contribution. Dr. Senia Bilolitseva, trustee of the Breathe Well Initiative. Dr. Edward Kindene, also trustee. Ms. Georgina J.B. Forbes, also trustee. Dr. Sata Teresa Kabai at Bo Government Hospital. Sheku Failimo Matia, Mary Toka, Royal Papworth Hospital CEO, the Ministry of Health, Sierra Leone, Kingsgate Community Church, Cecilia Moifula, and people who have really prayed for us, Mrs. Sylvia Butau. And last but not least, my rock and my greatest fan, my husband, Mr. James Fofana, also trustee, and our children, Nyawa and Emmanuel. but sometimes just allowing us to get on with work. So I'm just going to share my slide now with everyone. Bear with me. Dorothy, is that appearing okay?
Yeah, everything checked. Thank you.
Okay. So before I continue to talk about my presentation, I'd just like to do a quick audience check. I'd like some thumbs up or in whatever way you like to respond. Have you ever struggled with breathing and you knew exactly where to go? You knew the clinic facility, there was a clinic facility and a hospital for you to go to. Just a quick reaction. Number 2, you know loved one, friend, colleagues, or anyone close to you who has and is still struggling with their breathing. Or 3, you have provided respiratory care for people with breathing difficulties, and you had all the equipment, everything you require close by without having to struggle. Many of us, we actually don't take into account the importance of lungs, the importance of breathing or air in our lungs. We only take notice of it when something goes wrong, and then it creates fear or challenges around us, especially people, our family members. That's when we take it seriously. And sadly, that is the reality of many people living with asthma and COPD. So I give you a quick definition according to the World Health Organization of asthma and COPD. Asthma, to start with, is a lung condition where the airways narrows and the lungs become inflamed. This inflammation it produces extra mucus, thereby making those individuals find it hard to breathe. And that causes wheezing, coughing, chest tightness, or shortness of breath. People who experience asthma attacks, it can be very life-threatening, and the triggers can be exercises, warm or cold air, infections, pollen, dust, pollution, and it can start from childhood or even adulthood. With chronic obstructive pulmonary disease, it is long-term, and it makes it difficult for people to breathe because the airway is blocked. And under the umbrella of COPD, you have chronic bronchitis and emphysema. So people who have COPD often have productive cough that lasts, and the breathlessness gradually worsens over time. And the major causes of that is smoking, indoor and outdoor air pollution, fumes, or dust at work. We know COPD can't be cured, but it can be managed with the right and appropriate management or lifestyle changes. You can manage it, live with it longer. So I did some research, and I looked at the global estimate of people actually having asthma. And approximately 260 million people globally suffer from asthma. In high-income countries, unearthing the condition asthma is a lot more easier than many other countries. The research also showed that 37 new cases are presented daily of those with asthma. For COPD, 213 million people are living with the condition every day. New cases are 16 or 17 million. Over the past 32 years, the disability adjusted lives years associated with COPD has risen sharply. And I was really, really surprised during my research to find that 68% of COPD-related deaths and disability actually happens in low and middle income countries. So why has it taken us so long in Africa or to bring respiratory care or better respiratory care to low and middle income country? Why is it now only that we are all trying to champion better health care, better respiratory care? I then looked at the socio-demographic index according to this research. And I found out that the largest country or countries where COPD is more prevalent is in the middle income countries like India, Pakistan, Bangladesh, some parts of Nigeria, Egypt, Morocco, and the low and middle income countries when it comes to age standardized rate. So like low and middle income country, they are not the ones that have like the largest cases of COPD, but when it comes to age adjusted between 40 to 70 years, the high prevalence and mortality rate is high due to indoor air pollution and biomass fuels. You can say this is also similar when it comes to high-income countries like the UK, America, Canada. They share sort of the same burden. But the difference with these countries is that they have better diagnostic capabilities, better capacity, better facilities for individuals who struggle with especially asthma and COPD. When it comes to death caused by asthma globally, daily, 436,000. That's a lot of people. And you see COPD, the third leading cause of death annually, about 3.7 million. There has been research in Africa, but we still carry disproportionate burden of respiratory diseases simply because of the absence of the appropriate infrastructure. And I wanted to see if I put out on a chart, like a pie chart, for example, I wanted to see what would be the exact representation of that. Now, when I'm talking about asthma and COPD, as a charity organization, our main focus is asthma and COPD. But there are other non-communicable diseases like cancer, heart condition. But there are a lot of research and work into the heart. But people, as I said earlier, we tend to forget that we breathe. Only when certain things has gone wrong, then we think about the breath that is in our lungs. And it's funny to see on this pie chart, non-communicable disease actually dominate mortality rate globally. We are able to find out from this because in high-income countries, the expertise are there, the research facilities are there, the training, the education is there for people to do this. And I just said, let me look at the countries that has improved expertise and infrastructure. Australia is well developed. We trained pulmonologists, respiratory therapists, advanced lung diagnostics. America, lots of specialists, doctors, strong research base. Germany is leading the respiratory care, strong integration of specialist services. We have Canada, Singapore. The United Kingdom is a global leader in respiratory health. You have most developed respiratory medicine system. The NHS, which is the nationwide, has nationwide access to respiratory specialists. They have departments. We have the British Thoracic Society, the National Institute for Health and Care Excellence. They are responsible for asthma guidelines, COPD guidelines, and other lung diseases. And major training centers, including the Royal Brompton and the University of London hospitals. So all of these countries, they have developed access to respiratory care. So then I looked at some of African countries. We have some African countries that are rapidly developing to actually close the gap on lung health inequality. But however, as I mentioned earlier, research has been done. We have the Chest African program that actually train healthcare workers in countries to do research. South Africa is developing, and they have like spirometry diagnosis, and they've got some data on respiratory condition. Egypt is also developing, and in that introduction is one of the centers that's actually now working to train respiratory therapists. Lung health has been around for decades, but yet Africa seems to be sort of catching up. Nigeria is also growing. It's got a number of pulmonologists. They've just recently, in the past few years, started having some spirometry access and national networks. Kenya is also coming along with Uganda and Ethiopia. So all of these countries, I'm proud to say Ghana is also having respiratory care system, training respiratory therapists for them to be able to care for the condition, even though there still remain some challenges, and that comes along with Liberia. But a lot of research is done. Sometimes we have to go beyond talking about the problem. We have talked about it. We have researched it. We know the problem exists. Now, how do we move into action to close the gap on care for people who experience everyday breathing challenges? Not only them, but their family members, or someone waking up in the middle of the night, fighting to open the window because they are struggling to breathe and not knowing what to do. Research will tell you we've got this data. Africa lacks this. Low and middle income countries, other low and middle income countries struggle to have expertise that actually care, that provides better respiratory services. And we thought if we move beyond talking and do more of action, we can see a lot of other African countries actually working to close that gap. Where inequality widens, we can work together to close the gap. We know you cannot differentiate between asthma and COPD without the appropriate equipment. A spirometer is required in order to detect the presence of obstruction and really giving a definitive diagnosis of asthma and COPD. And what the spirometer does is it assesses lung function by measuring the volume of air that the patient is able to expel from the lungs after they have taken in maximum inspiration. With the spirometer, you are able to get reliable data that differentiates between obstructive and restrictive disease. And you are able to also monitor the disease severity. As I said, in high-income countries, these are like services that are provided where patients are monitored on a daily basis to know the impact of their lung function. Other diagnostic tools, which is the imaging, such as the X-ray, it's very useful for detecting infections, and it's quite straightforward. You can use it at the patient's bedside. But when you now want to sort of differentiate whether it's cancer, lung cancer, whether it's chronic emphysema, bronchitis, really separating COPD into its classification, you need CT scan. And from all the research that I have done, in fact, I give example always of where I am from, Sierra Leone. The CT scan we had is about 150 miles away from Bo. So if you have patients who needed imaging requiring that, it required them traveling. And some of them don't have the resources or the transportation or even the cost of it. Yet these are all things that are required when we talk about respiratory health, so much needed. With all the equipment, we see that the challenges Africa is experiencing in terms of diagnosing respiratory condition is limited respiratory facilities. We do need to have infrastructures, centers, clinics, hospitals equipped to treat people who have breathing difficulties. We need the staff. We need the specialists to be able to manage the condition effectively. We need the tools, the diagnostic tools. We need the testing capacity. How do you pick up a condition quickly? It's by you having those equipment, those materials that enables you to pick those conditions up as quickly as possible. We need to increase the availability of medication. We need to look at the cost. How can we get people who cannot afford to afford? How can you increase availability of medication? We need some work to do when it comes to caring for respiratory health in low and middle income countries. So we wanted to use Sierra Leone as a pilot by first establishing a center. But look at this imaging, for example. Imagine a mother carrying her child on her back, and maybe she has other children around her, and on a daily basis, they prepare the family meal in an enclosed environment like this, thick black smoke. That child will grow up to have difficulties in breathing, or even the mother. But they may not link immediately their condition to their lifestyle, because for them, it's normal. This is daily living for those in Africa. So when we talk about lung conditions, individuals will not always think that my lifestyle can actually cause a condition, or maybe something that will restrict them from doing their everyday activities. So that is why we at Breathe Well Initiative, we've taken it upon ourselves to pilot this center in Sierra Leone. So I'll give you a quick background of Sierra Leone. You can see on the map here in Africa, it's this dotted line, extracted. The map is only 8 million people that lives, 8 million population in Sierra Leone. But as small as it is, it has gone through several challenges over the years, such as the civil war between 1999 and 2002. And you all know that war causes the economy to decline. It destroys infrastructures. And when you have a country coming out of such devastation, and then it goes through other challenges like Ebola outbreak between 2014 and 2016, it hampers the economy. Other natural disasters, and more so as COVID-19, which really highlighted the challenges the country is facing when it comes to respiratory care. In addition to that, there is increase in prevalence of COPD. And these risk factors are associated with several things: smoking, age, lung growth and development as biomass fuels, socioeconomic status. Many people cannot afford, even if they have the condition, they would rather buy a bag of rice. Let's say one COPD medication or asthma medication can actually buy a bag of rice for a family of 4. Now, someone who has asthma condition or COPD, they are not going to go and buy inhaler. They would rather feed their family. And that's the reality of many people that live in Africa who have conditions like respiratory health. So what is the aim of our charity? We aim to set that lung clinic in Bo. Don't know if you can see Bo here on the map. We thought, my husband and I, we come from Bo. And so it was only important that we actually start the work in Bo. But another reason for that is Freetown is 150 miles away from Bo. So if you look at people from Kono, Tonkolili, Moyamba, Kailam, Pujeong, so if you set a clinic in the capital city, which is 150 miles, you're not going to actually catch the population that are actually experiencing the condition. So we want to be able to catch everybody, to have equitable, accurate lung diagnosis, and also start them on proper management pathway. We want to increase capacity building through training, research, collaboration, in order to allow us to provide evidence-based intervention. So we've gone from doing research, we've gone from talking to actually now action. So we have done quite a lot so far already. 2001, we registered the charity with the Charity Commission here in the UK. And our trustees are 5 of them only from various backgrounds. Our website, and more recently, our collaboration with the African Respiratory Care Association and the Global Asthma and COPD Outreach. We want to say that we are very glad to be collaborating with these amazing organizations. We have Memorandum of Understanding with the Ministry of Health. And what we also did in the last couple of years, we sponsored Sierra Leone's first ever COPD guideline, which is still in review because the country didn't have any. And when I mentioned Sierra Leone, remember, we are using Sierra Leone as a pilot because there are other African countries or other low and middle income countries that needs a dedicated respiratory centers. So Sierra Leone is a pilot. We are piloting this. So when I mention just Sierra Leone, just know that this, because we are doing that, we are working on the charity and we are using it as a pilot for that will be replicated in all of the other African countries or those countries that need the services most. So we have few partnerships in progress. Last year, we were able to purchase a land for the clinic operation. So that will minimize sort of a lot of spending, because if you do rent, it means that you're going to actually every year that adds on. But with a permanent location, it's sort of is more sustainable for the charity. And we have support from the Royal Purport Hospital CEO. But what I'm going to really talk about now is the pilot program that we conducted in 2024 and some of those challenges that we encountered and what we can all do going forward. So I put it on this graph. We first had to apply for ethics from the Ministry of Health. And in Sierra Leone, in different regions, there are chiefdoms. So we had to get permission from the Bo Kakoa chiefdom, from the chief that was there. Then we had a temporary facility. We made sure that that was set up appropriately to ensure diagnosis, worked with Bo Government Hospital, with Dr. Sata, and I had some state-registered nurses and the community health officers that came on board. And most of the trustees, they are based in the United Kingdom. So what one of our trustees did was to offer training via Teams to all the workers that were with me on the ground. But other challenges that we encounter in Africa is power outage. So that's why we are very glad for Zopec batteries, because you can be doing something and suddenly the light just goes off. We were doing training, the light went off. And at that time, we hadn't actually factored into account fuel for generator. We then had to rent generator. One of the trustees did a quick fundraising in the UK to get us money to buy fuel, which is what when we had power outage, we then switched to the generator in order for us to carry out the training as well as the other activities. And whilst we were doing that, we did radio campaign, and that took us, we had 7 days radio campaign on and as well as word of mouth. We had the overall chief and the local chief. So they were like advertising for us through word of mouth that this clinic was going to come to do some pilot program. So on the day we opened the door for everybody to come in. So since research is my background, I gave the patient the PIS, because you can't just go and want to collect data from people. You want to ensure that you've done it ethically. So I gave them the PIS. Those who were eligible, they consented. We had an admin who collected the patient demographics, name, address, date of birth. And we did height, weight. We did the CAT score. And also, we were very mindful of patients who had TB, tuberculosis. So we had a strict guideline. Patients who were struggling or who had symptoms of TB, we worked directly with the Bo Government Hospital. So when we see patients who have had symptoms of TB, we sent them to Bo Government Hospital for them to do screening. And if they were negative, then they came back to us to continue with the lung function. And if they tested positive, then they were put on medication. But obviously, because we were only there for a very short period of time, we made sure that we worked directly with the Bo government hospital so that these patients carried on receiving care and treatment. We gave education, peak flow meter, and then we did the lung function. We had this handheld equipment. I don't know if you can see. This is ATS approved. Obviously, in high-income country, this device is used by individual patients, and they are able to monitor their lung function over time. So when they see their patient, when they see the doctors then able to check what the condition or what their lung capacity, what their condition is. So what we did, this data would give information about the patient, and it will allow us to download it. So we downloaded the data and sent it to the UK to Dr. Senia Bilolitseva, who then reviewed it, analyzed it, and then send the data back to us and say, this person has severe COPD, is restrictive, is obstruction, or we need to give this individual asthma inhaler for them to open up their airways and so on. But obviously, because we were operating on limited resources and the time we were there was very short, meant that those we have already seen, they are waiting on us to continue with the action. So in just 3 weeks, I was there for 6 weeks, but because of ethics, the setup, advertisement, and everything, in only 3 weeks, we were able to screen 200 patients. If you see the bar chart here, to our surprise, there are many other conditions available, presented in Sierra Leone. Interstitial lung disease is one that we were not expecting to be there, but both asthma and COPD, 24%. But because of data integrity, if you see the unknown one, there's 45% of that. That's because this device is used by individual patients, some of them were doubling up. And for data integrity, we didn't want to include those data. But I'm sure if we are to go back and do a lung function test, among that 45, we will find majority of them having lung conditions. 83% of these individuals have lung conditions in Sierra Leone, and every day they go to bed with it and carry out their daily activities. So really think, when we talk about respiratory condition, when we talk about breathing difficulties, there are stories behind the people we see, or the images, or the data. This lady here holding this spirometer, she's been struggling. She told me she will wake up in the night. She's got a son as well. She will wake up in the night not knowing what to do, especially when she gets the attack. She didn't know how to use the inhaler. She didn't know what to do. She will struggle to open the window and the door, panicking. If you have family members, someone you know that struggles like that, it sparks urgent action. So for our vision at the Breathe Well Initiative, we don't want to leave it at the pilot stage. We want to extrapolate that. We want to get the clinic set up, train healthcare professionals who are equipped to manage asthma and COPD. We want to increase diagnosis from 200 to 1,000 in the next year. For those people that we trained, that we screened, we were only able to put 10% of them on inhalers. Now that's nothing. Because right now, I feel the burden. Because when I think about these individuals we have screened, and I know they are struggling. One man came, fell down in the clinic, struggling for air. We had to mobilize him. When we put him on inhaler, we allowed him to stay in the clinic until he has mobilized because he had severe exacerbation. When we put him on inhaler, for the week we were there, his symptoms improved. But when we left and the inhaler finished, he went to the government hospital. Sadly, that man didn't come out of hospital. He died. And even on oxygen. For me, what that tells me, it could have even been interstitial lung disease because the lung was no longer absorbing the air he was getting. He has gone worse. So we don't have to wait until it gets worse for us to act. We have researched. Now let's do the action. So that 10% that was put on inhaler, we want to increase that from 17 to about 830. We want to be able to finalize other partnerships, individual to come on board to ensure that this clinic not only serve temporarily, but it can be the beginning of many other dedicated respiratory clinics to come in Africa and other low and middle income countries. The gap is too wide. Training gap is wide. Equipment gap is wide. So the only way we are able to close that gap is to go from that talking to doing and make sure that there are individuals able to receive the health care that they need. So in 2027, we want to even increase that. Again, more individual, more trained staff, more respiratory therapists, more collaboration, screened 1,000 patients to 2,000, increase treatment from 830 to 1,000 to over 1,000 or 2,000. We want to be able to have expertise exchange. People from low and middle income countries should be able to come to high income countries to be trained. And people from high income countries should be able to go to low income country to train respiratory physician. That's how we learn. That's how we learn about individuals. That's how we learn about the disease. That's how we learn about the prevalence. We learn about the characteristics. That's how we do training. So that's our vision for the next 2 years. But we need to do this in collaboration. And that's where I'm proud to say ARCA and the Global Health, Asthma and COPD Outreach coming. With joint awareness and advocacy, we would be able to increase infrastructure, training, and the educational system, where when people come from university, there is a pathway for them, not just learn, and then nothing else. But there is a pathway for them to be educated. And they will go on to train other healthcare professionals. That's how we build capacity. That's how we then invest in resources. We develop and disseminate policies, guidelines in order to manage the condition. We research together and we are able to share our data to influence policymakers globally. Because we need Africa represented on a global scale. We need individuals to be able to sit in those meetings in those high-income countries where policies are made for them to advocate for individuals who are suffering with respiratory condition. So why do we need respiratory therapists in Africa? Well, throughout, as has been mentioning, there's high burden of respiratory diseases based on the lifestyle. Asthma, COPD, tuberculosis, pneumonia, COVID, all these are leading causes of illness and death. And there are many people that are dying every day with this condition. There's a critical gap, as mentioned, critical gap. We need specialist training. We need people who knows how to operate ventilators. When a child is struggling with breathing, we need somebody who would know exactly what to do, who would know how to operate oxygen therapy, who would know how to record the data, who would know what to do in that instance, who is expert in it. Those in ITUs, we need to increase our workforce. We need to work together to provide the skills required to ease the burden of respiratory conditions worldwide. We need the education. Respiratory therapists can teach our communities. They can do outreach. They'll be able to know what are the risk factors. They'll be able to say, if you are cooking in a closed environment, maybe make sure that your air, the area where you are cooking, it's more ventilated. Instead of being in the smoke, inhaling it, make sure there's enough air around you. We need people to do outreach. We need them to teach them about air pollution, smoking, avoiding smoking, how to use inhaler correctly, not just in Africa or low and middle income country, even in high income country. There are people, last week we heard from Dr. Azuri teaching us about the bridging the gap in medications. Many people don't know how to take simple inhalers. So we really need the expertise to be able to train healthcare workers and the patient so they can be able to manage the condition even when they are not in the clinical area. Because sometimes it's not just about them being clinical, but the people, the social side of them as well, they can learn. And these people can also become advocates once they are trained. We need to strengthen our health system by improving patient outcome, reducing hospital stays, and saving lives. RT can make healthcare work more effective and cost-effective. With ARCA and their fight to reduce the burden of respiratory diseases and strengthening the workforce, promoting innovative respiratory services, respiratory care, and improving the care around Africa and beyond. And GACO, we can all work together. Everybody here listening to me will be able, this is not a one-person job. This is an individual. This is not an individual, but a group work in order to ensure that we give the best services that we need to give to our patients. So on that note, I'd like to say we are calling on everybody to join the TBWI, the Breathe Well Initiative vision. You can support our clinic building project or scan the QR code on the screen to know more about what we are doing. Together, let's breathe life into Africa because breathing well matters. Thank you.
Thank you so much. Thank you for an excellent and an insightful presentation. Thank you, Dr. Fofana. We are so grateful. And before I read the Q&A, I would like to give the opportunity for the ambassador for Guyana to Switzerland, and then a representative from the UN in the person of Dr. Leslie Ramsamy to say a word or two.
Thank you very much, Dorothy. Thank you, colleagues from various African countries. I know my colleagues in Guyana are also listening. Let me thank a few people first of all. Dorothy and the African Respiratory Care Association. Congratulations, Dorothy, and congratulations to ARCA. Let me thank and congratulate Dr. Dama Fofana for a very insightful presentation this evening. I am not certain if our colleague, the Minister, the Honorable Minister of Health from Ghana, is on this afternoon, this evening. But if he is, then I want to say hello. I met the minister here in May, and he expressed his interest in promoting lung health and respiratory health in Ghana and support the movement to improve respiratory health and lung health across Africa. The importance of lung health and respiratory health have been underlined by Dr. Fofana. And I will say something about that. It is for me unfathomable that a condition that in terms of chronic respiratory diseases, 455 million people living with those conditions. And each year, 4 million people die from chronic respiratory diseases. But in fact, at any one moment right now, about 700 million people live with respiratory illnesses or conditions that affect their health. We sometimes forget that in addition to the chronic conditions that affect more than 450 million people, about 500 million people on an annual basis suffer from infectious diseases where their respiratory conditions deteriorate. And yet, our investment in respiratory health has not matched the disease burden. Um, and it's not just that our investment in respiratory health does not reciprocally reflect the disease burden. In terms of our human resource for health, we don't pay enough attention for those professionals that we need to ensure proper diagnosis and proper treatment. We also have not appreciated the fact that respiratory professionals, whether it's the doctors, nurses, or respiratory therapists, are required not only for the direct respiratory illnesses, but there are other conditions in which respiratory function deteriorates and contribute to more serious illnesses, cardiovascular diseases, for example. So it is an undervalued and underestimated health issue. I will say this, that we cannot achieve universal health coverage, and we cannot achieve the targets under the SDG 3 if we do not change the imperative and if we do not change the dispensation. We need more investment. We need more attention to respiratory health in the developing countries. And so I'm urging this evening ministries of health across the developing countries and Africa and the Caribbean have a unique opportunity to revolutionize UHC and health for all. And so I'm going to urge this evening that as professionals, as ministers of health, as governments, that we invest more in the training of professionals, that we invest more in equipment and technology. If you think about things like sleep disorders that are very much linked to lung health, very few developing countries have dedicated sleep programs, sleep health programs. Sleep disorders are not being addressed. And so I want to congratulate those countries like Guyana, like Ghana, like Sierra Leone, Ethiopia, and so that are now paying attention to these things and investing this. And if the Minister of Health of Ghana is listening, I want to say to you, sir, it is very commendable, the investment being made and the interest being paid. Training programs like those for respiratory therapists, think about it. Of the more than 100 developing countries in the world, we have only a handful of countries with certified training programs. This is unacceptable. And I'm disappointed that the WHO has not done more to promote respiratory health and lung health and develop those programs that we need. And I don't want to spend a long time, but I will end on this note. That these things don't happen by chance. These things happen when we improve services to our people, It happened by deliberate action, by a vision, by commitment, and by dedicated people. We need champions for respiratory health and for lung health. And clearly in Africa, with people like Dorothy and Dr. Fofana and others, there is a growing cadre of champions for respiratory health. I am profoundly impressed and profoundly grateful to those champions in Africa. We need champions similarly in Guyana. And I am proud to say that Dr. Willima Bacchus has been a champion in Guyana. Champions like Dr. Bacchus, champions like Dorothy and Dr. Fofana and others are going to be the reason why in 2030, health for all will be much stronger than it is today. So to ARCA, to Dorothy, to Dr. Fofana and others, to Dr. Bacchus in Guyana, I say to all of you, thank you very much. The citizens of the world owe you a lot. So thank you very much. I am grateful, impressed, and honored and privileged to be part of today's session. Thank you all very much.
Thank you, Dr. Ramsamy. So you heard from the Guyana ambassador to Switzerland, Dr. Leslie Ramsamy. Thank you so much. Now, with all being said, ARCA has a message for all of us. If with all that has been said, with all that has been done this year, this particular message encapsulates everything. And we are about to share it for you. It's very brief. Just stay tuned, and then after that, we read out your questions. So use that opportunity to type in your questions, and then we'll read them out after this session. Thank you. So I call on the IT team to show the video now.
Dear esteemed partners, supporters, and friends, it is with sincere conviction and a deep sense of purpose that I extend this message to you on behalf of the Africa Respiratory Care Association, ARCA. Founded in 2024, ARCA is a legally registered non-profit organization in the United States of America and Ghana, and an official chapter of the International Council for Respiratory Care, ICRC. We are driven by a singular, urgent mission to advance respiratory care in Africa through education, advocacy, policy development, professional growth, and international collaboration. Our vision is bold but necessary to ensure that every country across the African continent has trained respiratory therapists and accessible, high-quality respiratory care services, regardless of economic or geographic limitations. Our core objectives: advocacy. Be a strong advocate for respiratory therapists, working towards recognition, licensure, and regulation in all African nations. Public awareness. Raise awareness about respiratory health issues and the role of respiratory therapists through public campaigns and community outreach. Annual conferences, organize annual conferences featuring world-class speakers, workshops, and cutting-edge research in respiratory care. Student exchange programs. Facilitate student exchange programs, allowing respiratory therapy students to gain international experience and perspectives. Promote excellence. ARCA is committed to advancing the standards of respiratory care in Africa through education, research, and best practices. Professional development. Offer continuous learning opportunities, scholarships, and mentorship programs for respiratory therapists and students. Collaboration. Foster connections with respiratory care associations worldwide to exchange knowledge and expertise. Facilitating global partnerships. Collaborate with healthcare professionals to advance the practice of respiratory therapy in Africa. Despite the immense burden of respiratory diseases in Africa, from asthma and COPD to tuberculosis and post-COVID complications, most of our countries lack a trained respiratory workforce. Presently, only Ghana, Egypt, Liberia, and Ethiopia offer respiratory therapy as an academic and professional path. This gap in care continues to leave thousands of lives at risk. The COVID-19 pandemic revealed what we already knew. Respiratory therapists are essential. Globally, demand is rising, projected to grow 13% between 2023 and 2033 in the US alone. Yet in Africa, a critical shortage persists. ARCA was created to fill that void. We are advocating across the continent. We are engaging with ministries, universities, and healthcare institutions. We are raising awareness, hosting training sessions, and creating professional networks. We are building the future of respiratory care in Africa, but we cannot do this alone. We are calling on governments, donors, international organizations, healthcare institutions, foundations, and individuals to support our work. Your contributions, financially, technically, or collaborative, will help us. 1. Establish new respiratory therapy programs in African universities. 2. Train and equip the next generation of respiratory therapists. 3. Provide scholarships and learning resources. 4. Host conferences, research initiatives, and public health campaigns. 5. Expand our reach to underserved regions and strengthen local systems. Every donation, every sponsorship, and every partnership helps us breathe life into a continent that needs it most. Your support is not just a contribution to ARCA, it's a contribution to health equity, to saving lives, and to empowering African healthcare systems for generations to come. We invite you to join us. Partner with ARCA. Support our mission. Help us realize a healthier Africa, one breath at a time. For sponsorships, donations, or inquiries, please contact us at info@africareps.org or sponsorships@africareps.org. You can also visit us at www.africareps.org or call the following numbers: USA +1 952 228 1482, Ghana +23 3242 130397. Thank you.
Thank you very much. Okay, so I move on to the questions. It says, from the earlier video, I learned that only Ghana, Liberia, Ethiopia, and Egypt has respiratory therapy program established in their universities. My question is, what is the Africa Respiratory Care Association doing to help other Africa countries establish this important profession in their universities? Looking at the challenges in reaching African leaders. Okay, so what the Africa Respiratory Care Association is doing is that we are engaging with lots of government officials, government stakeholders like the Ministry of Health, Ministry of Education, and all educational regulatory bodies. So in Ghana like this, apart from the Ministry of Health and Ministry of Education, we are also engaging with the Allied Health Professions Council. And very soon, I'm sure the Ghana Tertiary Education Commission would also join forth. We are engaging all these organizations and ministries to hear our mission and understand the profession in the first place. Thereby, they can add it to their policies and then support the training of respiratory therapists in these countries. So we have done a lot of engagement, and I want to use this opportunity to thank University of Bosaso in Somalia, University of Chan University in Cameroon. We also have done some outreaches in some other places that is yet to be concluded. And in Nigeria, some other states have also identified the need for this profession, and then there are lots of talks and communications going on. So you would hear the news and the story of Nigeria very soon. I also want to ask another question. It says, thank you, President Dorothy, and your team for these webinar sessions. As a nurse, ARCA has increased my knowledge of RT program. I am from Ghana, and I have started interacting with RTs. It's a joy. Thank you so much. Thank you. We really appreciate your contribution. Thank you so much. You said if you were to convince everyone to be an RT or help ARCA set up respiratory education in other African countries, what would be your message? Okay, so if I were to encourage someone or convince somebody to be an RT, I would say that being a respiratory therapist or the respiratory therapy profession is a life-saving profession. We are dealing with the cardiopulmonary system, even though the other systems of the body are very important. But remember that the engine of the body is the lung and the heart. And therefore, respiratory therapists play a key role in identifying or managing patients who have some form of challenges with those systems. And we don't do that alone. We do that with the support of other clinicians as a team. So the role of respiratory therapists cannot be overemphasized. So that would be my message to convince somebody to become a respiratory therapist or to start a respiratory therapy program. And then a message from Javier Ramirez. It says, thanks for your lecture. That is Madam Fofana. Thanks for your lecture. Definitely, it shows the reality of the emerging countries. Like in the Latin America, we have a similar condition. However, it's very relevant to understand the next point. Now, his point is number one, what is the average cost for healthcare system for the healthcare system, respiratory therapy exacerbation? So it has to do with what is the average cost that the healthcare system would spend on respiratory exacerbation. And then number two, who paid that? So when it comes to, okay, I get what you mean. And then show the benefits, that is the savings for early and preventive interventions. And then the fourth one, it says identify areas where the prevalence of respiratory diseases are most relevant. And then the fifth one, it says, okay, so the implementation and screening program for low costs is a good idea. Okay, so I get what you mean. So all that the person is trying to say is that who pays for what, and we should identify the areas that are very prevalent and thereby identify those areas for screening and all that. So please, your message is well noted. We'll note it down and then we can contact you. For further discussion, you can also reach the Africa Respiratory Care Association at info@africaresp.org. You can look at the chat session to see our details, and our details will also be displayed on the screen. You can reach us for further discussions. And then still on Javier, he says, congratulations for your actions. It's a big challenge. So Dr. Fofana and ARCA, this is a big challenge, but by the grace of God, we will get it done. And then Dr. Ngozi Ibe says, this is amazing and an eye-opener. It got me tearing up. We need to move from talking to action. we need to have more passionate people to set up, not looking for what they gain. And she says hashtag compassion and empathy. So this is a take-home message to everybody. This is an action time. If you are a stakeholder, a government official, anyone in the ministries hearing us or listening to us, respiratory therapists are calling on you to add this to your policies. Introduce the program and support countries that are already having the program to expand with various amenities and facilities that they need. Thereby, we produce the quality respiratory therapists that Africa needs. And then from another person, it says, that from your presentation, you said Sierra Leone, you have a memorandum of understanding with Ministry of Health. How are you able to collaborate with the Africa Association to also establish the profession in Sierra Leone University? So this question goes to Madam Fofana. It's asking about how the collaboration with ARCA, how is it going to also help a university in Sierra Leone start the program?
Thank you very much for that question. Well, the collaboration with ARCA and the memorandum memorandum of understanding with the Ministry of Health is to give us the opportunity to work with the government hospital, especially in Bo, because the clinic is a day clinic. So if you have patients who have severe exacerbation and they need an overnight stay, you want to have them in a hospital environment, which will be the Bo Government Hospital. So that allows us to actually work together with that hospital. With ARCA coming in, we come in with training, expertise, and we are talking, it's a bridge for us to actually work with the Ministry of Health to establish ARCA's mission of training respiratory therapists, actually factoring it into the educational system, into the universities, because people need to be trained. We need to train respiratory therapists in Sierra Leone. So that's the way I'm looking at it in actually working together.
Okay, thank you very much. So what ARCA is also doing on the side to support Sierra Leone is that through the Breathe Well initiative, we are using that collaboration to reach out to their Ministry of Health as well. So, and sometimes getting to these ministries, you need to, it's a series of calls, series of meetings here and there, but we are making frantic efforts to reach the ears of the Ministry of Health. So I believe that in some few years to come, Sierra Leone would also have some universities having the program established. Please keep your questions coming. I want to use this great opportunity. Dr. Chris Owu has been a pivot in strengthening the respiratory care program in the clinical settings as well. He has also been involved in the training of hands-on sessions, apart from classroom sessions. And I would want to give him the opportunity to say a word or two before I move on. So Dr. Chris O, you want to say something? Okay, so when Dr. Chris O is ready, he is going to unmute his mic and then let us know. Okay, so on that note, please bring your questions. I'm still reading more questions from here. Okay, so I would also want to use this opportunity to let everyone know that all our webinar series for the year 2025 has been saved on our YouTube channel. So you can visit the Africa Respiratory Care Association YouTube channel and you can see all the educative sessions that we had this year. We've also had sessions in French, Arabic, Portuguese, and as well as the English language, all educating people in respiratory health and respiratory care. You can also visit our LinkedIn page and follow us on LinkedIn. You can visit us on Facebook and Twitter and Instagram pages. So you can just screenshot this and then you follow us after the session. Thank you all so much. Okay, so on this note, I'd want to ask the IT team to put some promos there and then we can close our session. And before the promo comes, we have Dr. Olubenga. He is the Director for Programs. And these webinars that we have or we've been having would not have been successful without him. So Dr. Olubenga Agbelemoshe, you can unmute your mic and then we see you and then you can give us a word or two before we wrap up. Thank you very much.
Yeah, good morning, everybody. Good evening, and good afternoon to where you guys may be participating from. Thank you all for your support in attending the ARCA webinars. We hope that we will be providing more information like this in the coming years. And any topic that you guys feel like you want more of, please let us know so that we could find some African doctors, subject matter experts that can actually facilitate the topic. We thank our president for facilitating this webinar today, and we thank everyone from wherever you are for participating, because we know that your time is valuable, and we appreciate that at least in the past hour to an hour and a half, you guys have been able to spend that time with us. So thank you very much, and we look forward to you attending future webinars that is going to be supported by ARCA. Thank you very much.
Thank you very much. I also want to use this great opportunity to thank our advisory board and our board of trustees for their support over the year and for our initiative. Thank you all so much. I want to use this great opportunity to also thank all country directors of the Africa Respiratory Care Association for your support in promoting and championing respiratory care in your respective country. Thank you all so much. And dear participants, a big thank you to you for staying with us throughout the year. We say Ayiko to you all. Well done and God bless you. You can watch all the sessions that you might have missed on our YouTube channel, so you can have all for yourself. And if you need certificate, kindly reach out to the Africa Respiratory Care. Look at the chat page. We have the links over there. You can contact us and we can provide you a certificate for participation. On that note, I also want to use this great opportunity to thank Dr. Leslie Ramsamy. Thank all the team from Guyana that participated. I want to also use this to thank the Ministry of Health representative and the Allied Health Professions Council representative and University of Ghana College of Health Science representatives. Thank you all so much. And most especially, I want to say a big thank you, and we love you, Zopec Medical, for making all our year, as in the 2025 webinar series, a success. Thank you for promoting respiratory health across Africa, and thank you for providing innovative solutions to save lives. Thank you, and thank you. It's bye-bye from here. you.